The following podcast is part of a certified educational activity titled Achieving Therapeutic Innovation in ALL, Insights on Modern Asparaginase Compounds in Pediatric, AYA, and Adult Patients. Access the entire activity and complete the post-test at peerview.com/JPA860. Downloadable slides and practice aids are also available.
Hello everybody and welcome to today's educational session on achieving therapeutic innovation in ALL with a specific focus on asparaginase. Today's panelists are Kjell Schmiegelow from the University of Copenhagen and Wendy Stock from the University of Chicago and myself, Nicola Gökboget, from the University of Frankfurt, Germany. We would like to thank the Medical Learning Institute and the Peerview Institute for Medical Education for providing the session, and particularly also Jazz Pharmaceuticals for providing the educational grant for the symposium. And now I'm very happy to start the session with a few very personal remarks on the shape of modern ALL care, what I personally think is important, and introduce the different asparaginase options. Now, in the management of adult ALL and pediatric ALL, we made a lot of progress in the past decades. The outcome in children is far better than 80% now overall. In younger adults, we are going up to 70%. But in older patients, we still have a problem with early mortality and also higher relapse rate and still a poorer outcome. And in relapsed ALL, despite the introduction of new compounds, still the overall outcome remains poor. So although we have improved results for first-line therapy in all age groups, we still rely mainly on intensive chemotherapy, which is essential for cure. But there are a lot of limitations, like late effects, for example, development of resistance, and there are still non-satisfactory results in relapsed refractory ALL. So on one hand, we need to optimize the use of standard of care chemotherapy compounds, and one of these compounds is certainly asparaginase. But we also need to use new targeted compounds with different mechanisms of action earlier during the treatment algorithm. Now a brief survey on the compounds which became available in the management of ALL. So in the 1960s and 70s, the combination chemotherapy with CNS effective compounds was introduced, also the use of L-asparaginase. And in the beginning of the 2000 years, the pegylated asparaginase and Erwinia asparaginase were introduced in the treatment algorithm. More recently, targeted compounds came into place. So imatinib was approved for Ph-positive ALL, blinatumomab and inotuzumab for the relapsed refractory ALL. Later also the first CAR T-cell product, and blinatumomab for the use in MRD-positive ALL. Rituximab was used in a randomized trial and showed an improvement of event-free survival, another important targeted drug, and nelarabine is now already introduced as a T-cell targeted compound into the first-line treatment in childhood and adult ALL. Now, which other developments do we have to mention? First of all, I would briefly touch the issue of genetic subtypes. ALL overall is a rare disease, and this leads to the fact that also the genetic subtypes of ALL are very rare. And in the meantime, by sequencing methods, we can identify up to 22 different molecular subtypes of ALL. And there have been a correlation to outcome as well. You can see on the bottom, for example, on the right side, the Kaplan-Meier curves for adult ALL. But I think that these results have to be interpreted much carefully, because you can see here, for example, the outcome of Ph-positive ALL, and this shows you that these data are not achieved with more recent protocols where the outcome of Ph-positive ALL is around 60%. So first of all, we don't know which outcome is associated with these subgroups of ALL, for example, when they are identified in modern protocols. And also for most of these subgroups, we don't know the optimal therapeutic consequences. Now, another issue which is heavily discussed in ALL are age effects. And on this slide you can see the outcome of ALL according to age, and it is very evident that the effect of increasing age on outcome already starts in the pediatric patient population. These are the upper curves. So even in the pediatric setting, the outcome gets poorer with increasing age, and this continues in the adult population. This is probably due to a higher frequency of poor prognostic features with increasing age, but also to a lower tolerability of intensive chemotherapy. These differences in terms of outcome according to age led to some confusion on the definition of age groups in ALL and patient groups which are identified for certain treatment strategies. So in the ongoing larger trials, very variable age groups are addressed. For example, 1 to 25 years, 25 to 65 years in the UK, or in the NOFO study 1 to 45 years, or in the CLGB 17 to 39 years. So this is of course a problem because it makes results less comparable. In Germany, just as a remark, we use adapted pediatric protocols up to the age of 55. In younger patients, younger than 18 years, they have full pediatric protocols, and in patients older than 55, we have reduced pediatric protocols, but all of them are pediatric based. Now, in younger patients, I have already mentioned the outcome has improved considerably with these pediatric-based regimens. The outcome is up to 70% overall survival at 3 years, as elucidated by this table. One very important parameter is the use of certain treatment approaches, some of them coming from pediatric trials, for example, the use of asparaginase, high-dose methotrexate, optimal use of maintenance therapy, and better protocol adherence. And there are also promising approaches coming from adult trials, for example, MRD-adapted therapy or the use of targeted therapies and the transplantation in high-risk patients. Asparaginase has a major role in this discussion, and I just want to show you briefly an experience from our German ALL study group where we have intensified the use of PEG asparaginase. PEG asparaginase was used already since 1999 in our protocols, and we have increased the dose in induction and consolidation, and the data from more than 1,200 patients show that we have no impact of its intensification on CR rate or on MRD level, but a significant impact on overall survival and remission duration. And this is seen in younger patients and in older patients up to the age of 55 years. So this underlines the importance of this compound and the optimal use, and we will discuss that later in detail. In older patients, we need to adapt the pediatric-based regimens, and the discussion is always which is the right age cut for this decision. And there are many data around this, also from our group, but also from the French group, showing that at the age of 55, the tolerability of pediatric-inspired protocols decreases. For example, in this trial, the death in CR rate raised up to 27% in patients aged between 56 and 59 years when they were treated according to a pediatric protocol. So this is maybe an important age cut where we need to reduce the therapy and particularly pay care to certain compounds. What we know in for older patients is that such protocols which are adapted to the age groups have the best results, although the results still need a major improvement. One example is, for example, here the German ALL trial for older patients. The major difference compared to the younger patients is that we don't use aspiration induction, but only during consolidation therapy. However, it's also clear that major improvement in older patients can only be obtained probably by the use of new targeted compounds. Here are two examples. For example, the replacement of the standard induction by inotuzumab in the initial 1 trial, and the use of blinatumomab in consolidation for the EVOLVE-BOLD trial. Just briefly, the interim results from these trials, you can see here a high CR rate with inotuzumab induction and also a high CR rate after blinatumomab, 84%, and the overall survival looks at the moment promising, although the follow-up is still short. There are also other trials ongoing with new compounds, which I want to briefly mention here. For example, the Alliance trial, a phase 3 trial with inotuzumab, and the E1910 trial with randomization of blinatumomab. Also in pH-positive ALL, a lot of progress has been made. We know now that by the use of tyrosine kinase inhibitors, we can improve the response rates, even if the chemotherapy is very much reduced in induction therapy, and offer more patients a stem cell transplantation. So far, there is no clear superiority of second or third generation TKIs in the adult setting. And for relapsed refractory setting, we have blinatumomab, inotuzumab, and CAR T cells, which are also effective in pH-positive ALL. Newer data go in the direction to combine TKIs, for example, with blinatumomab here, as is shown in the Italian trial, where high response rates are achieved and also a promising interim data for overall survival. We have to keep in mind that in this setting, many patients have received a stem cell transplantation, that we need a longer follow-up. Now, in relapsed refractory ALL, there are promising results regarding the use of blinatumomab and inotuzumab. Both compounds are superior to standard of care chemotherapy, but the overall survival in this patient population is still poor, around 7.7 months for both compounds. The best results have been reported for blinatumomab when it was used in the MRD setting. And this is a brief summary of this trial, and I think this is a direction to move forward. We have a 78% molecular CR after only one cycle and a promising survival of 36 months median. However, 70% of the patients approximately have received a stem cell transplantation after blinatumomab. Finally, let me briefly mention the CAR T cells. This is just to show you that there are not so many trials in adult ALL, so we need more experience here. And the marketing authorization is currently only available for patients up to the age of 25. One important remark for the CAR T cells is also here from the real world data showing that patients, this is the blue curve, treated in full relapse with high tumor burden with the CAR T cells have a rather poor outcome. The best outcome also with the CAR T cells is achieved with a setting of MRD positive ALL. Now we would like to move forward to the use of asparaginase, because this is a very important drug for the standard of care management of ALL, which is still the cornerstone for the cure of our patients. Asparaginase has some complexities, so it is discontinued in many of the patients because of toxicity, whether justified or not, we will discuss. PEG asparaginase is used in first line in many high-income countries, and again, there are some problems with toxicities and discontinuation. And Avinia asparaginase is used in patients with hypersensitivity in the standard of care, but there are drug shortages which have challenged the use of Avinia asparaginase. And just to briefly remind you about the different formulations, the major difference here is the duration of the activity, which is far longer for PEG asparaginase compared to Avinia asparaginase, and leads to the fact that you don't use only one application compared to 3 weekly applications for Erwinase. So in today's agenda, we will discuss the challenges and therapeutic options for optimizing asparaginase therapy, and also the experience in older and adult ALL. So I would like to introduce you now Kjell Schmigelov from the University of Copenhagen, and to present on his data with a focus on pediatric and young adult ALL.
Thank you, Nicola, and thank you for letting me participate in this important session where we address not just how we are to treat patients now and in the future, but also how we deal with certain challenges that we face due to the toxicity of asparaginase, which has now become quite a critical drug, not just for pediatric leukemia, but also in the adult setting. So it's a long history dating back to the start of the 20th century when asparaginase activity was first detected. And then an increasing number of studies that emphasize its efficacy, both in first and second line therapy, with a number of different formulations having been approved. First, the E. coli-based asparaginase, later on the Avinia-based asparaginase, but also pegylated asparaginase due to a longer half-life. And I have this slide with a picture of a family of 4 generations, just to emphasize that this is really a drug that crosses the generation and is efficacious in all age groups. But it's not just a question of efficacy, it's also a long list of toxicities that we face and need to deal with when we use asparaginase. Things like pancreatitis, hypersensitivity, thrombosis, liver toxicity with hyperammonemia, but also other characteristics of liver toxicity, with including hyperbilirubinemia. Some patients, not least when we give it with steroids, will face hyperglycemia, and a number of patients will experience hyperlipidemia. And we'll go through many of these toxicities during today's session. But I'd like to start off with a patient case where we had a different representation of pancreatitis. So this case is a 4-year-old girl with acute lymphoblastic leukemia. She was diagnosed February this year with a B-lineage leukemia, a white cell count of 30, and she had CNS involvement. When we state CNS3, it means that she had leukemic cells in a cerebrospinal fluid in a number above the normal leukocyte limit. She received a 3-drug induction with relatively non-myelosuppressive drugs with incretin, dexamethasone, and asparaginase, day 4 and day 18, that was the planning. She had no risk genetics. In fact, she had a 1221 translocation. Her day 15 bone marrow was negative by flow cytometry. It was also negative by flow on day 29, but there was a low number of residual leukemic cells when explored by PCR on the clonal immunity arrangements. And she was stratified to our intermediate high-risk group based on the presence of CNS involvement. On day 18, before she received the second exposure of asparaginase, she had symptoms of pancreatitis. And when I say pancreatitis, the patient needs to fulfill at least 2 out of 3 criteria: enzyme levels above 3 times the upper normal limit, symptoms compatible with pancreatitis, and a positive imaging of the pancreas. So what then to do? So this is how it looks. She got asparaginase early March, and approximately 2 weeks later, she developed her first episode of asparaginase-associated pancreatitis. Her lipase was relatively high, 176, so it's almost 5 times the upper normal limit. The amylase was tripled, and she had abdominal pain, so in principle, she fulfills the criteria. Importantly, her ultrasound and CT scan were normal. So how should we deal with this issue, which is not unusual? So I want to share with you some data from the Nordic study. And as Nicola pointed out, in the Nordic setting, we used our treatment protocol for patients from the age of 1 to 45 years. And that allows us to compare the risk of pancreatitis during this quite heavy asparaginase-loaded protocol. In total, patients were to receive 15 doses. And as you see, the risk of developing pancreatitis is growing throughout therapy as more and more exposures to asparaginase is given. And the risk seems to be almost identical for the older children, 5 to 8 years, the adolescents, and also the young adults. It doesn't occur immediately when you give the drug. It occurs at a medium time of 10 days from the last episode, but it can be up to 3 to 4 weeks. And it occurs after a medium of 5 pegylated asparaginase doses. And you see when we compare the older patients to the very young children, 1 to 4 years of age, they have an accumulative risk that is approximately half of that. Importantly, it's quite a toxic complication. 3 out of 4 will develop systemic inflammatory response syndrome. 1 in 5 would need mechanical ventilation. 1 in 4 will develop pseudocyst. And at least 1 in 5 will have recurrent pain after the pancreatitis episode. And importantly, when we compare the patients below 10 years of age to the older patients, among the older patients, 1 in 5 will develop insulin-dependent diabetes, which is way beyond what we see in the younger children. So that's a specific complication. One thing is that you have the pancreatitis, which may be severe enough in itself, but 1 in 5 of the older patients will have permanent insulin-dependent diabetes. And when we look at all these complications, they are far more common in patients 10 to 18 years of age and somewhat as common in the older patients. So should you re-expose or should you not re-expose? And what you see is data from what we call the Pontellier study, which is an international consortium of pediatric groups across the world. And on the right, you have the Nordic data from patients 1 to 5 years. And in both of these cohorts, if you re-expose the patients, approximately 45, or you could say almost 1 of 2 patients will develop a second episode of pancreatitis. But importantly, we don't have the ability to identify any risk factors that you can do to decide whether or not to re-expose the patients. So age was not a risk factor for developing the second episode, and also the severity of the first pancreatitis was not a risk factor. However, the older patients tended to develop the second episode early on, 1/3 always after the first re-exposure, but that was just the case for 1 in 7 of the children. So if you want to re-expose, a number of the younger children will be able to tolerate quite a significant number of doses, on average 3 to 4. For the older patients, it will occur more early on, but also you need to anticipate the risk of whether they could develop diabetes. So let's look at how we dealt with this specific patient. So she had her first pancreatitis already after the first dose. She had a subsequent episode without additional exposure, just emphasizing that this complication can come and go, where she had elevation of the enzymes, not very profound, and she had abdominal pain, but still an ultrasound that was normal. And we thought that although her MRD was low, she did have CNS3. She's only received so far 1 dose. And the second episode wasn't really pancreatitis. The first one was reasonably mild, so we decided to re-expose the patient. When we re-exposed the patient, she had her second episode of pancreatitis, an elevation of the lipase, but it was accompanied with minimal abdominal symptoms. We didn't do imaging at that time point because the abdominal symptoms were so weak. But we then considered she had these risk factors. She only received 2 of the 8 planned doses, and the symptoms were relatively mild, so we decided to give her the 3rd dose. So this is the second pancreatitis case. But when we gave her the 3rd dose, she had much more severe pancreatitis when measured by the lipase levels. These now went up to almost 10 times the upper normal limit. It was 15 times the upper limit for amylase. She had quite severe abdominal pain, but she didn't have a systemic inflammatory response syndrome. She didn't need a ventilator. And when we did the CT scan, there was clear pancreatic edema. So these were our consideration. Although she had a low MRD in the bone marrow, negative by flow, and very low by PCR, she had at least received 3 of the 8 doses. And when we looked into her cerebrospinal fluid, which we monitored by flow, she became negative after the first intrathecal therapy. And for these reasons, we decided to stop further asparaginase exposure. So this is a complicated case. I think it would be great if Wendy and Nicola would comment on how they would have dealt with such a specific case in their age group.
Yeah, Cal, that is a very difficult case. And I think what we would have done, I think we might not have been as courageous or as aggressive about this as you have been. I think that perhaps we often use the CT findings and the clinical symptoms, as you were saying, to make a determination of whether to re-expose. And if there is only enzyme elevation with very mild symptoms, we do consider re-exposure. So I think the first episode there, we may have considered a re-exposure the second time. But I think, and I completely understand what you did, and I'm admiring of what you did. But I'm not sure in the adult groups, because of usually the increased severity of the pancreatitis, that I personally would have exposed on that third exposure.
Yeah, thank you, Wendy. I agree with that. So actually, we use the criteria defined by Kjell Schmiegeloff for classifying pancreatitis, and in severe cases with CT changes, we don't re-expose the patients. But what we in addition do to what Wendy said, we would reduce the dose and maybe leave out one asparaginase, because you have it, I think you have it approximately every 14 days, and maybe we would leave some time to recover, and maybe start with a lower dose again, and look for the duration of activity, because some patients have really prolonged activities, and this shows a big variation between patients, and we would consider that as well.
Thank you so much for these important comments. So one of the reasons why we are so aggressive in the therapy is a number of studies that has come out from the pediatric world. We don't have the similar amount of data from adult patients with leukemia. But as Nicola pointed out early on, that approximately 1 in 4 patients needs or have some toxicity that leads to truncation of therapy. So this is a list of studies that's been published from the pediatric world that demonstrate that the more aggressive or more intensive asparaginase therapy do lead to higher cure rates, basically also showed by the DML data that Nicola pointed out. So when you truncate therapy, for whatever reason, whether it's hypersensitivity or in this case pancreatitis, the patients with truncated therapy seems clearly to do worse. So it's really a question of a plague or cholera. So what we tend to do is we balance what we think the risk of a second episode of pancreatitis compared with the risk of leukemic relapse. So for instance, if this patient had been a standard risk leukemia with negative MRD, no CNS involvement, we may have been more reluctant. In a case where we classify patients in a group where approximately 15% would relapse, we are much more prone to re-expose. In the re-exposure studies that has been published, it's quite interesting to see that even patients that had what we would call severe pancreatitis, sometimes even patients with pseudocysts, were re-exposed, and we couldn't find any linkage between the severity of the first and the second episode. I'll come back to 2 of the last papers, the one from the US group Gupta and one from the Nordic group. And this is data from the Nordic group. And here what we did was we classified patients on any kind of truncation, where we said truncation low intensity is patients who have either truncation, that they were not exposed, so they had less than 10 weeks of asparaginase therapy, or that the patient had low enzyme activity when we measured that in the blood sample. And for these patients, the risk of relapse were 12%. In contrast, the black curve, that is patients that had no truncation, that had positive enzyme activity, the relapse risk was only 7%. So here, in contrast to many of the other published papers, we combined inactivation of asparaginase with an actually truncation of the therapy. Another quite common toxicity is the asparaginase-associated hypersensitivity. So this is clinical hypersensitivity, meaning that the patient has symptoms. It may even be quite mild, but what we know is that even in the mild cases, so there's no real anaphylactic reaction, sometimes just a local rash, that these patients have antibodies in the bloodstream and they will inactivate asparaginase. Some groups have used steroids, antihistamines, to control these hypersensitivity reactions. It may change the clinical situation, but the patient will still inactivate the drug. So yeah, there's a need to switch to non-E. coli-derived asparaginase. There's also patients who have intolerance. That means they have symptoms that could be compatible with asparaginase hypersensitivity. They may have a rash, they may have stomach pain or vomiting. They tend to come later, and we use plasma activity monitoring to be able to distinguish between these two settings. If it is hypersensitivity, whether it's silent inactivation or with clinical symptoms, we know that clinicians need to shift to a non-E. coli-derived asparaginase, which will, in principle, always be ervinase. And when patients do that, their outcome is very similar to those without inactivation. So this is data from a US study that compared the benefit of pre-medication, and it clearly improved the tolerance to asparaginase. What you need to do, if this is what you want to implement in your clinic, then you need to do therapeutic drug monitoring. These are data from the COG group that demonstrate that if you have patients with hypersensitivity and you do shift to providing Erwinia asparaginase for these patients, the outcome is exactly the same as those patients who did not have hypersensitivity reaction. But if you discontinue, the risk of relapse is clearly and highly significantly increased. So the main conclusion from this study is that hypersensitivity in itself do not matter as long as you recognize it and give patients an alternative formulation of asparaginase, in this case, Erwinia. There's been a number of studies ongoing internationally on how we should implement therapeutic drug monitoring, or TDM, in the setting of asparaginase therapy. So you need, of course, to measure the activity. You need to target your therapy for trough levels above 0.1 international unit per mil. Some groups have tried to measure antibodies and asparaginase activity. It's not really useful. Antibodies may be measured, but they don't correlate very well with the pegylated asparaginase enzyme activity. And asparagine will be depleted in your blood sample, and thus you cannot use it. If you have grade 1 reaction, you may apply monitoring to see whether it's truly an inactivation. But if you have grade 2 to grade 4 hypersensitivity with rashes and other symptoms, you always need to switch. The TDM is also beneficial for detecting silent inactivation. And as I mentioned before, it's good to discriminate between hypersensitivity and allergy-like symptoms. We define silent inactivation as asparaginase activity below 0.1 day 15 or below the lower limit of quantification on day 14. And in these cases, as I said before, you need to shift. And as I said, if you use pre-medication, you always need to do TDM because you may easily mask the hypersensitivity and thus the inactivation. If you compare the hypersensitivity for children and for adults, the symptoms that patients will experience is basically the same of any kind of anaphylaxis that you know in your setting, whether it's asparaginase or something else. But there's a tendency for adults to develop hypersensitivity less common than in children. And we also demonstrated that in the Nordic study where all the patients were treated on the same protocol with the same dosages. Hypersensitivity was less common in adults, also if we adjusted for the risk group that they were stratified to. So if you have the symptoms, as I said, you do need to interrupt. It's fine that you use these pre-medication, but you always need to shift to Avinia. So what are the options today? When we know there's been a marketing problem with Avinia, the production line hasn't been sufficient for the universal needs around the globe. This has been a growing problem. It's been growing because more and more protocols not only recommend monitoring, so we capture silent inactivation, but also recommend shifting to an alternative formulation, in this case, Avinia, in case of hypersensitivity reaction, however mild they may be. So what are the alternatives? I just want in this setting to mention that some patients, especially if you experience hypersensitivity, sometimes even at the very first dose, in some of these cases, it is really antibodies directed towards the PEG moiety. And in this case, you may have sufficient enzyme activity if you shift to the native E. coli. For the far majority of patients, you need to shift to Avinia. The Jazz company have recently developed recombinant chrysanthapase, which is based on Pseudomonas. It's a much more stable production, so we anticipate in a few years that Jazz will be able to deliver Avinia completed to the need on the global scale. What you see here is the published comparison between conventional Ervinase and the novel Pseudomonas-based chrysanthapase. And the pharmacokinetic curves are very similar. There haven't been data coming out where we know exactly how you could convert the milligram per meter square for the novel product with the older activity units. But as you see, at least from a pharmacokinetic basis, this intramuscular testing, and this is just single dosage, the curves are very, very similar. In parallel, there is studies ongoing to compare IV as well, and also if you shift and give the novel formulation on a 3-weekly basis, that is, you give it Monday, Wednesday, and Friday, what would be the relevant dose? Should you change for the Friday dose so the patient is covered over the weekend, or should I have the same dose throughout the week? That is something that is being explored currently. There's another formulation that has been tested currently. What I show you here is data from a Nordic study on erythritase, and this is asparaginase encapsulated into erythrocytes. So the basic idea is you have the drug, it can deplete asparagine within the red cell that is given as a blood transfusion for the individual patient, but the antibody cannot eliminate the drug. We have tested this in 55 patients and a total of 225 doses. It has been highly efficacious, even though all of these patients either had hypersensitivity or in a few cases silent inactivation. The drug levels achieved was as was anticipated and highly effective. And this efficacy is also seen that some of these patients did experience hyperlipidemia or hepatotoxicity and even osteonecrosis as would have been expected. So far, no case of pancreatitis has been reported. We don't know exactly why that is the case, and higher numbers is needed. And there was a few patients who actually developed allergic reaction. So this is a medication that we anticipate will be brought to the market within a recent time scale and would probably come in as a third-line therapy. Another toxicity that we experience with asparaginase is Trombo Embolism. And what you see here is also from the Nordic study, where we treated almost 2,000 patients from 1 to 45 years. And in this cohort, 137 patients developed thrombosis with a cumulative incidence of 8%. But the incidence is very, very different between the younger children, less than 10 years of age, that is the lower black curve, compared to the adolescents and adults who almost had a similar rate of 15 to 20%. It's not really surprising in the way that we know that asparaginase depletes both antithrombin, protein S and C, and fibrinogen. And when we give that also with steroids, the steroids can increase prothrombotic factor, like factors 8 and von Willebrand and PI1. And if we look at potential risk factors, and in this study we also looked at whether we could use targeted SNPs that in other studies had been known to increase the risk of thrombosis. We found that the candidate SNPs on fibrinogen and factor 11 were clearly risk alleles, and we combined that for a risk score. It could be clinically useful for the adolescents in the way that the younger children, less than 10 years of age, in any case, irrespective of their genetic profile, had a relatively low risk in the order of like 5%. And on the other hand, the older patients, 18 to 45 years, had a high risk of thrombosis in the order of 20 to 30%. But in the adolescent group, patients that had these genetic risk factors had a risk of thrombosis of almost 40% compared to only 10% for those without this risk score. Then that may be used for future prophylactic therapy. And one of the therapies that has been tested, at least in children, is the use of low molecular weight heparin during the early phase, that is during the induction therapy. What was found in this randomized trial is that both low molecular weight heparin as well as antithrombin 3, when that was given prophylactically, the risk of thrombosis was clearly reduced. There was a worry that the 83 substitution could have led to an increased risk of relapse, since the 5-year event-free survival was clearly reduced. So currently, the conclusion from that study is that thromboembolism may be reduced by using low molecular weight heparin. We don't know whether the more novel oral anticoagulation drugs can work in the same way, but clinical trials are ongoing for that setting. A number of study groups have claimed, but they have all been retrospective, have claimed that various ways of prophylaxis could be beneficial for adults with leukemia. We recently published this Cochrane review based on 23 non-randomized adult studies, and they were all burdened by various kinds of bias, meaning that as of today, we do not know whether there's any appreciable benefits or whether the harms are acceptable when using thromboprophylaxis for adults with leukemia. So there's clearly that there is a void and a need for randomized trials in the adult setting, and that's highly relevant because the risk of thrombosis is so high. It may lead to truncation of asparaginase therapy, and as I said before, they could lead to increased risk of relapse. A third toxicity that's worthwhile addressing, because it's recognized more and more frequently as we use asparaginase in adults, is the risk of osteonecrosis. And what you see in this study, again, from the Nordic group comparing patients 1 to 4 to 5 years of age is that adolescents and younger adults have almost the same risk of developing osteonecrosis, but the risk of osteonecrosis seems to be skewed. So the youngest children have their cases of osteonecrosis very early on. The adolescent group tend to have it somewhat later, and the adult group tend to have it the latest. And in fact, half of all adults that did develop osteonecrosis developed this toxicity after the cessation of maintenance therapy. So you need to continuously monitor these patients, and if they come with pain from a joint, even a year after cessation of therapy, you still need to think about whether this could be due to osteonecrosis and do an MRI to confirm that. We did a smaller study to see whether lipids could be associated with the risk of subsequent osteonecrosis, and these are the peak triglyceride levels during delayed intensification, and there was a very strong association with the risk of subsequent osteonecrosis. We don't know whether any lipid-lowering therapy will be able to prevent this, but randomized trials on using omega-3 are currently ongoing. So in conclusion, adults tolerate asparaginase-based therapy almost as good as the children, and at least as good as the adolescents. But these AYA group tend to do worse overall than the younger patients. If we truncate therapy, the risk of relapse is clearly increased, whether the truncation is due to stopping the therapy or due to silent inactivation. And we can only distinguish these two scenarios by using therapeutic drug monitoring. If you want to re-expose the patients who have developed toxicity with asparaginase, you need to think about what is the risk of relapse compared to the risk of unacceptable toxicity. So that's really an individual setting, and it's difficult to write that into the protocol, and that is very much the local clinician who needs to consider this. Specifically for the adolescents and young adults, you need to be very cautious with pancreatitis because the increased risk of developing insulin-dependent diabetes. And when you have hypersensitivity, you need in nearly all cases to shift to alternative asparaginase products with non-cross reactivity, and for the time being, this is Erwinia-based asparaginase. I have listed in the table some cutoff limits where you clearly see that it varies by age groups, and you need to take that into account. So thank you for your attention, and I'm looking forward to discussing some of these issues with Nicola and Wendy.
Yeah, thank you very much, Kjeld, for your excellent talk and the impressive data all coming from your NOFO studies. That's really excellent. So we have a few questions to discuss, and current times, probably we have to address briefly the topic of COVID because there are some questions around this, whether we modify our protocols in patients with infection or throughout the whole pandemic, particularly regarding the risk of thrombosis. So maybe you can briefly comment, and Wendy, and maybe I afterwards.
So there was a lot of worry when everything started early last year. We didn't, in our setting, take any precautions, and now as data have been accumulated, we know that some children will develop this systemic inflammatory syndrome. It hasn't been reported really in children with leukemia in a very large database, which is hosted by the St. Jude Research Hospital, and I think we by now have 1,500 patients. There's a few patients that are going to very severe lung symptoms and end up in a ventilator, but this thrombosis issue haven't really been exaggerated in that specific setting with leukemia patients who, for some reason, are found to be positive with COVID. So we do find a number of patients who, just because of the screening, are found positive with COVID. We don't change that therapy currently if they don't have symptoms, so it's an asymptomatic culture positivity. If they have symptom but very limited in a very limited degree. We will continue with non-myeloablative or very strongly suppressive therapy because we want to keep the lymphocyte count normal. And so far, we haven't seen any patients who've had thrombosis issues and COVID positivity. I don't know when they have a different attitude because you have so much more older patients with other comorbidities.
You know, that's a great question, Kjeld. I think we still don't know exactly what, if any, modifications need to be made. But we too, initially, we were a bit worried about using all of our standard agents during the pandemic. On the other hand, we went ahead because of, as you point out so beautifully in your talk, you know, delaying or omitting drugs results in poorer outcomes. And so our clear goal was to continue with the therapies. One of the interesting things, and to the point of the thromboembolism, my personal experience is so far that I have not noticed that as an increased risk in our patients getting treated actively for in our young adult or even in our older adult population with the asparaginase. One of the interesting things that we have thought about a little bit that we were a bit worried about was the fact that some of the vaccines that we use here in the United States, the Moderna and the Pfizer vaccine, may have pegylated material, polyethylene glycol in it, and that we were a bit worried that during vaccination, perhaps, some of our patients who had hypersensitivity reactions to asparaginase would have hypersensitivity reactions to the vaccines. And we were initially, several of them, we brought into the clinic specifically and monitored them very closely while they were getting their vaccination because we were a bit worried about a major hypersensitivity or anaphylactic reaction. And in our few cases, we have not yet seen that either. So we have generally just been going ahead with our treatments in patients who are exposed to COVID, who have active COVID. We've been holding the therapy during the active infection and then resuming treatment when they become clearly asymptomatic.
So I can only add that also we didn't change our treatment algorithm during the pandemic because we're still heading for the cure of the patients. And the only exception is probably if a patient has a COVID infection at the start of induction therapy and you don't know where it goes and what can happen because some patients have rather long are virus positive, and therefore we would probably not give asparaginase in this situation when it's unclear where the patient is going. So maybe avoid the asparaginase just during the induction phase, but this happens really rarely. Yeah.
So since the vaccines are approved for patients or individuals above 16 years, at which treatment phase or when would you vaccinate your patients?
That is a great question, and it's one that we're asking ourselves and our patients are asking us frequently. We have been, in general, we've been waiting until the patients are in maintenance therapy to vaccinate them. Even then, one wonders whether or not it's appropriate. But what we've been doing, interestingly now, in our hospital, we have the spike antibody test, and we've been monitoring our patients whom we've vaccinated to see if they've mounted a response. And I can say happily that our patients who have been vaccinated during maintenance therapy have mounted nice responses to the antibody. This is just a handful of patients. Of course, it's not been studied prospectively.
Yeah, thank you all for the great discussion. And I would like to introduce now Wendy Stock to discuss asparaginase issues in adult patients and older patients.
Thank you so much, Nicola. And thank you both, Nicola and Kjeld, for these lovely introductory talks. I'm going to follow up on the beautiful presentation that Kjeld just made, focusing a bit on the hepatic toxicity in particular, which is a really vexing problem in our adult population with acute lymphoblastic leukemia. The objectives here are to really review the outcomes of pediatric regimens in the AYA population and describe the treatment-related toxicities with a focus specifically on the asparaginase toxicities and the relationship of obesity to toxicity and survival, and then a little bit about the strategies that might mitigate asparaginase toxicities and improve outcomes. Just to show you overall, you've seen a beautiful presentation at the beginning from Nicola of the overview of the adult population with ALL. And these are our CALGB studies over a number of years showing overall, and this is until the early 2000s, survival of about 41%, very much divided, as Nicola showed you, by age, and where we have now made major improvements in the young adult population because we have adopted the pediatric regimens with intensive use of asparaginase, glucocorticoids, vincristine, and more intensive intrathecal therapy. What we have found is that these regimens are feasible with low treatment-related mortality, as was shown by Kjeld, and the toxicities are manageable, but they definitely increase with age, and that there have been, because of these regimens, major improvements in event-free and overall survival, with, as Nicola showed you, survival now over 70% in many of our AYA protocols. So these pediatric regimens have become the standard of care, but toxicities limit the use of these regimens in older adults. And just to review again, the beautiful data from the Nordic group on the approach that was used to treat all patients ages 1 to 45 years with an intensive regimen that was risk stratified by specific biological and response features, including minimal residual disease. And you can see here excellent survivals, again, less good for the 18 to 45-year-old patients, but still remarkably better than any historical control data that has been published in the past. And in the United States, here are our historical data of the outcomes of young adults, and this is truly very young adults, ages 16 to 21, where our survival rates were only about 46%. This is from 20 years ago, compared to the children's groups, where the survival rates were approaching 70%. Using the pediatric regimen then, as we've just discussed, we have now also improved the survival rates to over 70%. And now we're just going to focus a little bit on a particular case because these patients do have unique toxicities. This is a patient of ours, 30-year-old man with precursor BALL. He really had no other comorbidities at presentation other than obesity. He had standard risk in terms of karyotype, normal male karyotype, ALL, but he had obesity. His BMI was 37, which is quite high, and he underwent induction therapy on the 10403 regimen. It was, as all of our patients were, treated as inpatient, and he really tolerated the treatment quite well. He was not febrile, but over time and on day 15 of induction, we noticed that his bilirubin has risen from a normal level at diagnosis prior to treatment to 5.6. His SGOT and SGPT have risen, and his glucose, he is now hyperglycemic, using a pediatric intensive regimen that has included early on high-dose steroids and exposure to pegylated asparaginase. So the discussion points really are, why is this happening and what do we do now? And we can stop here potentially and just ask my colleagues what they think is going on. I think they know what's going on and what they might do about it. Nicola, would you like to comment?
Yes, Wendy, I'm not aware which dose of asparaginase you are using in this protocol.
That is a very good point. We used 2,500 units per meter squared with no cap in this protocol.
So this is something which we have observed in our studies is that these patients with a high BMI or pre-existing steatosis have a really high risk to develop severe liver toxicity during induction. And this often leads then to prolonged interruptions of the whole therapy because you cannot or you do not dare to continue the chemotherapy. And in order to avoid this, we decided to reduce the dose in these patients for the initial asparaginase. So we only use 500 units per square meter in these patients with BMI above 30 or steatosis. And if this goes well, we start with thousands for the next dose and maybe further increase, but this is dependent then on the duration of activity. So what we want to avoid is initial severe toxicity when you then really cannot anymore conduct a reasonable treatment in induction.
Yes, thank you so much. I think those are really important points. Kelt, have you seen this quite frequently in your Nordic population?
I have a few comments to it. So I completely agree with both of you that hepatic steatosis is clearly a risk factor, and it is patients that are obese. It's also leukemic infiltration. So if we take if you took liver biopsies at the time of diagnosis, every single patient would have leukemic infiltration. And delaying asparaginase to a later time point during induction therapy seems to be one way to solve the issue. And that is something that is now recommended for older patients in this setting. So I think that there is an option to avoid it. And we don't really know whether for the long-term outcome, it's beneficial to give asparaginase early on. There's, of course, the risk that if you delay it, more patients may be stratified to a higher risk group. So, of course, that needs to be balanced. But I think it's partly the leukemic infiltration issue with the steatosis. And that is probably why when we give exactly the same dose during induction, but perhaps not at day 4, but at day 22 or day 25, we see a lower incidence.
Oh yeah, Kelt, this is an excellent point. Because I can confirm that when we started to use PEG asparaginase, we started to use it in induction at day 11 or around this, and this was rather toxic, and we stepwise moved it to a later time point, which is now day 20. But still, there is a strong correlation between steatosis, BMI, and liver toxicity, also for this time point.
Yes, thank you. I think we're going to touch on many of these really important points as we move forward. And we've learned some lessons because exactly what both of my colleagues have said about the increased toxicity in our older patients, even though they're quite young in age overall. And interestingly, we recently did a comparison study of the toxicities in young adults with ALL who were treated on this 10403 regimen compared to patients the exact same age who were treated who were treated on Children's Oncology Group protocols with the identical induction therapy. And what you can see here is quite fascinating to me in that even though it's the same age range, the median age was different. In our adult protocol, slightly older, the median age of these 17 to 25-year-old patients was 20 years, and in the COG was 17 years. And even in this small difference in age range, you see tremendous differences in toxicities, including hyperbilirubinemia and hyperglycemia, as you saw in our patient. And so thus, while treatment-related mortality is low on our protocol, on the 10403 regimen, further dose intensification in this manner for AYAs and older adults may not be feasible. And I think we need to consider some of the very important points that both Nicola and Kelt just made in terms of modifying toxicity. So the hepatotoxicity resulting from asparaginase treatment is thought to be a consequence of protein synthesis inhibition and amino acid depletion, which results in metabolic stress and generation of reactive oxygen species, which eventually result in apoptosis of the hepatocytes. Asparagine depletion of glutamine may also play a role, and mitochondrial stress and dysfunction can lead to altered lipid metabolism, accumulation of unoxidized fatty acids, which we'll come back to a bit later, and result in diffuse steatosis and hepatic necrosis. In our CALGB 10403 study, where we did the comparison to the pediatric regimen, I think one of the very fascinating things is that the BMI of our patients was higher than in the average pediatric population. And you can see in this slide that hepatic toxicity overall increased significantly with BMI. up to 62% in patients with morbid obesity, and 8% of our patients fell into that category. And similarly, in the red box, you can see that all of the liver enzymes were grade 3-4 toxicities were significantly higher with increased obesity. This did not occur in the lower panel with the pediatric patients, where, of course, there were fewer in the higher BMI ranges, even within that same age range. And you can see that this led to very poor outcomes indeed for our obese patients on the 10403 regimen. And quite shockingly, as you can see here, those with morbid obesity with BMIs greater than 40 had significant early dropout due to early treatment failure and poor survival rates. In our multivariate analysis, really, of this protocol, biologic features including the pH-like ALL with high CRLF2 expression and BMI were the two most important pre-treatment prognosticators in multivariate analysis in this trial. Of course, MRD undetectability, a treatment modifying measurement, was of course a very key prognosticator as well. But in terms of pre-treatment factors, BMI and biology of the disease were most important in terms of outcome. And there was recently a very interesting paper published that shows that the adipocytes, and this has been shown previously, but again, very nicely shown, that adipocytes can nourish ALL, and obese patients have far more adipocytes than other patients, and that these adipocytes can enhance chemoresistance. And in this very recently published study, what is seen is, if you can look on the upper left, what you can see is that this was done in vitro, but basically fatty acids were given to the leukemia cells with an overlay of adipocytes. And the adipocytes were able to donate the oleic acid to the leukemia cells, resulting in increased chemotherapy resistance, interestingly. And that this resistance to treatment could be overcome to some degree by inhibiting fatty acid synthesis within the adipocytes, and then they weren't able to transfer the fatty acids to the leukemia cells as well. Similarly, the leukemia cells themselves were not able to synthesize fatty acids, and that was able to result in improved cytotoxic death in these patients who in these cell lines of patients in these cell lines of acute lymphoblastic leukemia. So the risk factors for asparaginase toxicity are that obesity is number one. It's the most common risk factor, but age, as we're going to show, and Nicola already showed, diabetes, high BSA, dose intensity of the asparaginase, low pretreatment albumin, and low platelet count and ethnicity contribute to asparaginase-related toxicities. Nicola already showed you this slide, but this is from the French study, and you can see here that with age, toxicities, particularly from asparaginase, increase significantly, and that once you reach age 55, you really cannot tolerate these pediatric regimens due to increases in toxicity, and just like our patient, rises in bilirubin, which result in treatment delays and sometimes abandonment of treatment. The genotype of the leukemia of the patient, pharmacogenomics, may play a very, very important role. And in this study, showing you here, there are specific genotypes that have been associated with increased hepatotoxicity due to asparaginase. And in this particular study, a superoxide dismutase, a metabolic detoxifying enzyme, was noted to have a specific genotype in patients that had a higher rate of hepatotoxicity, and that this hepatotoxicity occurred more commonly with this CC genotype, and that this genotype was, interestingly, associated with patients who identified as Hispanic ethnicity. So you can see here that the CC genotype is actually more common in patients with Hispanic ethnicity. And as I showed on the previous slide, Hispanic ethnicity is associated with increased hepatotoxicity, perhaps because of the metabolic profile in these patients where metabolism to remove some of these reactive oxygen species is not as profound. So what can we do about this asparaginase toxicity? How can we improve therapy for obese and older patients? That's what I'm going to talk about a little bit now. Is it possible to prevent hepatotoxicity? Well, Kelt and Nicola both gave important strategies that have already been tried with some success. Can you delay the dose during induction? Yes. You might be able to avoid the inflammatory state during the first days of treatment, and this has been done in a number of studies, as both Nicola and Kelt mentioned. Also, lower doses with high cumulative exposure with frequent dosing can be used, and perhaps that will mitigate the liver toxicity to some degree. We'll come back to that in a moment. There have been no comparisons yet of the Erwinia asparaginase over the pegylated asparaginase that Kelt mentioned earlier, but it does seem that perhaps Erwinia may have lower hepatic toxicity rates. There has been no head-to-head comparison. And as Kelt was mentioning, therapeutic drug monitoring and personalizing dosing may be the key to preventing hepatotoxicity and yet delivering adequate asparaginase to patients. And we can measure asparaginase levels through commercial labs. And in our center, we routinely do this. We did a pilot study in our center to look at this issue, whether therapeutic monitoring and dose adjustment of asparaginase did result in adequate asparaginase levels, and whether this did decrease hepatic toxicity. And this was a pilot study with a median age of patients of 43, and 26 of them received reduced dose pegylated asparaginase with the goal of achieving a therapeutic asparaginase level as defined by Kelt earlier of the 0.1 international units per milliliter. And we started with a dose of 1,000 per meter squared versus the standard dose in the 10403 regimen of 2,500 units per meter squared. And as Nicola mentioned, we also reduced it further to 500 if the BMI was greater than 30 or older age or pre-treatment liver enzyme abnormalities or diabetes. And using this approach, 81% of our patients achieved therapeutic levels with the lower dose, and overall, grade 3-4 liver and thrombotic toxicities were significantly reduced. And here you could see that using 1,000 units per meter squared on the right, all patients achieved a therapeutic dose, a therapeutic level of asparaginase. At 500 or even 250, we were still in some patients able to achieve a therapeutic level, but in some of them we weren't. And as Nicola mentioned, we would then, if the patients were doing well, re-expose them to another dose of asparaginase so that we could hopefully deplete asparagine and get the desired therapeutic effect. So this is one possible mitigating strategy. What about pharmacologic mechanisms? Well, ursidiol prophylaxis is often used, but there is only anecdotal evidence. I do routinely use it through the intensive parts of treatment in my young adult and older adult populations to whom who are exposed to asparaginase. L-carnitine and vitamin B complex are necessary cofactors in mitochondrial oxidative phosphorylation and may be useful in treating drug-induced mitochondrial toxicity. There are numerous case reports and case series, and reasonable dosing is listed here on the slide, that it might be appropriate to give a loading dose followed by a stable dose in 3 to 4 divided doses per day for severe asparaginase-induced toxicity. The initial treatment should be administered intravenously due to low oral bioavailability. However, patients can then be transitioned to oral treatment. A phase 2 trial is now underway to evaluate prospectively the efficacy of L-carnitine and vitamin B complex in the treatment of pegasparaginase and inotuzumab, one of the drugs that Nicola mentioned early on, for patients with relapsed ALL that is ongoing, and this drug also can induce hepatic toxicity. So there is a prospective trial going on. And in the United States, Eitan Orgal has proposed a trial that has been approved by the National Cancer Institute and should be initiated soon, looking at patients ages 15 to 39 years from all of the cooperative groups in the United States, randomizing patients to L-carnitine to determine, in fact, in a nicely prospective study, randomized, whether we can decrease grade 3 asparaginase-induced or greater liver toxicity. And finally, I wanted to end with a fascinating study that was also just published in Blood Advances from Dr. Orgal and colleagues. This is a pediatric study, included some young adults, 10 to 21-year-olds. And what they did in these obese patients, not all of them were obese, was that they put them on a strict caloric diet and had a very strict exercise plan for these patients during induction therapy. And they compared these 40 patients who were enrolled on this study to a matched group of historical control patients. And what they found, interestingly, was that, in fact, this trial was called the IDEAL trial, that there was less gain in fat mass for the obese patients, not overall, but for the obese patients, as you can see in that top bar graph. Importantly, there was a lower risk of minimal residual disease, suggesting again that adipocytes and obesity contribute to treatment resistance, and that when you put these patients on a strict diet and put them in an exercise program during induction, there was in fact a decrease in minimal residual disease levels, and that there was a higher adiponectin leptin ratio, which is associated with insulin sensitivity, not insulin resistance. And so these patients became more favorably metabolically active during the induction therapy. This, of course, would need to be confirmed in a randomized study, but I thought it was a very fascinating approach that illustrates many of the interesting issues surrounding both toxicity and obesity that we face, particularly probably in the United States, more than in some of the European countries. So in conclusion, pediatric regimens have truly improved survival rates in young adults with ALL and has become the standard of care. Intensive asparaginase exposure is a key component for the success of these regimens, but major toxicity in the young adults is related to asparaginase, and hepatotoxicity, along with all of the toxicities that Kelt mentioned, is significantly higher even in the youngest of the young adult populations. Obesity and pharmacogenomics are important contributing factors, and obesity is a barrier to treatment tolerability and to treatment resistance, as I hope I've showed you. Strategies to modulate and avoid hepatotoxicity are being explored with asparaginase monitoring, which may allow for a personalized approach, pharmacologic strategies, where there are some prospective studies underway, and hopefully with some control of diet and exercise during treatment, particularly during the early weeks of therapy, may result in improved outcomes for our patients. And with that, I would like to close, and then we can take additional questions. Thank you very much.
Yeah, thank you very much, Wendy. What was really fascinating, particularly the data on the adipocytes and the obesity. And I would like to start with a question regarding this, because do we really know to which parameters the poor outcome of obese patients is associated? So have they more mortality, more complications, and therefore treatment delays, or more relapses, or a combination of everything? One question which we always discuss in this respect is, for example, the dosing of these patients. And I wanted to ask also both of you whether you have any clear guidance on that, because we don't have any guidance in Germany, for example.
It's the toughest issue, Nicola. I totally agree with you. I think it's a combination of everything. I think we have to very clearly try to define this better, but you could see from those survival curves that those patients are dropping off so quickly. And we did see increased toxicity for sure. I think there was a lot of treatment abandonment early on because of these toxicities. And perhaps if people had sort of nurtured patients through it and continued treatment, perhaps the outcomes wouldn't have been so bad. But nevertheless, it's something we really have to address. And we don't have really good guidance. And I do think your approach and Kelt's approach about potentially using these toxic drugs to lower degree early in treatment and then monitoring levels and adjusting the dose may be the best way to avoid some of this drop off.
Yeah, and we did a survey in Germany just to add this. The general dosing of cytostatic drugs in obese patients is not clear. So every hospital has their own strategies, or not even a strategy, so every doctor maybe. And I think maybe this is one issue which we should also address in the future. They can be overdosed, they can be underdosed. We don't really know it. Yeah. Okay, but Kjell,
I can add one comment. When we look at the treatment of infants, there's been a tendency to have one strategy for dosing. It could be then kilo-based dosing, and then further adjustment just by their age. And of course, we realize that you need to guide the dosing clearly depending on which drug you're using. So for a drug that distributes in a way that it's relevant to use the body surface, that's fine. But specifically for asparaginase, it only stays in the bloodstream. And that's much, much better associated with kilo-based dosing compared to body surface-based dosing. And I think it could be relevant when you calculate the toxicities, whether if you readjust it and see what was the kilo-based dosing for these patients, because that's related to the blood volume, where that gives some novel associations.
That's very interesting.
And also, you could say for vincristine, we always have a capping dose, and that capping dose means that the bigger you get, the less exposure you have. And I just wondered whether neuropathy, peripheral neuropathy, is much, much lower in these obese patients compared to the slimmer patients.
You know, it's a fascinating thing, but in fact, when we did our comparison of to that point, when we did the comparison of our younger patients, our AYA patients with the pediatric population, there was less neuropathy in the adult population. And perhaps that is because of what you're saying. It's quite interesting, actually. On the other hand, you'll have to think about the changes in metabolism that occur with aging, and I just don't know how that plays a role in
no,
all
but
of this.
I can mention an aspect we are now starting to study, that is that there's an endogenous metabolite, the 4-beta-hydroxycholesterol, which is a very good endogenous measure of CYP3A4. And this means that you may be able to just monitor that to give an impression of whether the patient is a rapid metabolizer compared to a slow metabolizer. And that could, for a number of drugs, be used to see whether that is associated with the toxicity, in addition to just having the patient's weight.
Yeah. Yeah, thank you very much. It was really interesting again. And but I think for the sake of time, we need to stop now. And thanks to both of you. I learned a lot. I hope the audience too.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/JPA860. This activity is supported by an educational grant from Jazz Pharmaceuticals Incorporated.